Now I invite Dr. Mandar JOGLEKAR from Kolhapur. He will be talking about Yamane technique and let us tell us about various making it easy for us.
So I'll be presenting the classical Yamane double needle technique, which was described by Dr. Yamane. So no financial interest. So it's a glueless and sutureless technique. Complete vitrectomy and removal of capsule is mandatory, as most of the speakers have already told. So this firstly we insert a needle, 27 gauge or 30 gauge needle as described by Yamane, Dr. Yamane, and we thread the haptic inside the bore of the needle. Then another needle is inserted 180 degree apart, and the second trailing haptic is inserted inside the bore of the needle. Then they are externalized by pulling the needles outside, and heat applied to create a flange so that they don't go inside, and they are tucked inside, and there ends the surgery. So important thing is mark the axis. So horizontal axis should be perpendicular, almost 90 degree to the wound, so that you can easily grasp the haptics easily. Then you have to make 2 millimeter mark from the limbus, another 2 millimeter marks in a clockwise direction, which has to be around 10 degree angulation to the limbal, parallel to the limbus. This is to accommodate the haptic angulation so that it doesn't tilt post-operatively. The same thing is done on the other side. So we insert a needle through the sclera from point A to point B, so that there is a path of intrascleral path of haptic is created and not just one point fixation. The IOL is injected inside. In this case, it's a foldable IOL. We use a vitreoretinal forceps. I prefer a max grip forceps to tuck it inside the bore of the haptic. You have to be very gentle with it so that you don't bend it. If you bend it, the final position of the haptic will be, of the IOL will be compromised. Next, another second needle is inserted. Again, a 2 millimeter tunnel is made while inserting. The trailing haptic inserted in the bore. This can be tricky, but with experience you can do it easily, because you are using a non-dominant hand, so that's the problem many of times. Both are externalized by pulling simultaneously, and we apply heat cautery to deform the ends. This is and we then push it inside and tuck them inside the tunnels we have created. And that is the end of the surgery. Nothing, no suture, nothing is required. So why 2 needles? If you just pull, some people advocate using one needle by first for the leading haptic, take the same needle on the opposite side after creating flange. But if you do that, the iris position, lens haptic position changes, so that it comes more anteriorly. It comes more towards the needle, and it becomes, you have to pull down the needle a lot on the haptics a lot, and so that it may get deformed, or haptics may break also. So it's better to use 2 needles. The problems with the 2 needles is anticipated is slippage of the opposite haptic in the vitreous. This happens in large eyeballs, particularly in myopes. To do away with this or handle this situation, we use a 27 gauge needle and not a 26 gauge needle, so that it has a firmer grip on the haptic, and scleral tunnels created are smaller in size. Another option is to keep one needle in place, as we are showing this haptic in this video. So we are threaded. After threading this, we take out both the needles, but keep one needle at place. Flange one haptic. and then you take out the another needle. This prevents slippage into the vitreous cavity. So pointers for the successful surgery is practice before you do. You have to get the feel of how it goes inside, how much resistance it applies, so that you don't do it inside the eye for the first time. And you have to do the markings meticulously so that the final lens position is well centered. I have already shown these markings. Angulation has to be accounted by while entering the eye. The correct optic position is slightly away from the tip. If you hold too close, it slips out. If you hold it a bit away, it can go easily inside the bore of the haptic. Now, the flange creation, what I've learned after some doing few cases is that you should not touch the tip of the haptic. You should just keep it away, and a radiant heat should melt the haptic and not the touch of the haptic. And you want to create a you have to put the radiant heat. One is the battery operated one, and this is the direct heat operated. And you have to create a flange like this, the first one, the conical one, and not a round one. If you get a round, if you produce a disc at the end, the disc will remain outside the sclera in the subconjunctival space, and that will create a problem of externalization or further problems in the long run. The conical end will go inside the tunnel you have created with the needle and prevent it from the externalization. So the final haptic position is this shown in the ASOCT. You can barely see the haptics in the sclera, fine touch, and they are entirely within the sclera and not in the subconjunctival space. So advantages are reduced surgical time, and there is an advantage of flap, and you can use it in very small pupil also. The flange advantage is that one small video of an animal eye, this so if you pull the haptic optic junction breaks essentially. Even if you pull it, but the haptic doesn't dislodge from the sclera. Stop moving. Can't move. Yeah, he is controlling. It was the last. And the small pupil also you can do this surgery because the optic stretches the pupil, and that allows you to do and you can use your needle to stretch the pupil in the opposite side so that you can insert it through those very small pupil as well. So many complications can happen as with any other technique. So thank you for your patient listening, and I thank Dr. Manish for inviting me from here and compiling a beautiful collection of the talk speakers. Thank you.
Thank you, Dr. Mandar, for